Good evening, everyone. Thanks for being patient with us and waiting a few extra minutes there while we were setting up. But tonight's CMT Connect webinar is with a very special guest, one of our favorite CMT surgeons, Dr. Glenn Pfeffer from Cedars-Sinai. So thanks for joining us tonight.
Thank you for having me.
Yes, I know you've been traveling and this is late hours for you, but we appreciate you joining us and just helping spread the word about the importance of surgery and all that goes into it, and how it can affect and improve quality of life for CMT patients. So thanks again. You want to tell us a little bit about yourself and your work experience?
I think I probably know a lot of you. Perhaps.
Yeah, we're getting a lot of hellos and.
Perhaps I've
Yes.
operated on some of you. Let's see if I got that right. So thanks for having me very much. It's a real honor and really almost a highlight of my career to do this. Thanks to the HNF, thanks to you, Estella, thank you for helping set this up.
Thank you.
And a special shout out, I think that's the term to use these days, to Allison Moore. Allison, I don't know if she's online, but
She is.
Oh, hi, Allison. But I've been interested in CMT for my entire career and my patients, but it was 15 years ago when I first got to Cedars that Allison really inspired me inspired me with CMT and to really forge on and to do more research. And I think certainly I'm here today in my career where I am in large part because of her get up and go and inspiration. And for those of you who know Allison, she's just a world changer. So thanks, Allison.
Yeah, that makes two of us.
And let's see, that's really it. We can get started.
Okay.
We can play this anyway, really. I think I'm going to try to get through a discussion, just some basics of CMT. A lot of the talks I've given, the thoughts I have are available online regarding bracing. But today I'm just going to focus on much more on surgery for CMT, because I think that there are a lot of myths about that and a lot of issues that have to be discussed.
Absolutely.
And just literally every day that I'm in clinic now, I see somebody who's needed an operation, couldn't find a doctor, is scared, all the things that make sense. And I just really want to reach out to people. And if it's not with me, with somebody that you can get to, who you can trust to do the surgery. But I'll be redundant. So let's see if I can get through. So what am I supposed to do? We'll share here, right?
Yes, I know you have some slides there to share with us.
Yeah, and then we'll have time so you can still see me. Is that right?
Yeah, we could still see you in a little window here in the corner.
Oh, good. That's good. I belong in a little window. And then what we'll do is we'll have time for questions. And
yes.
I don't know when we're supposed to stop, but I'll go.
No, we have a full hour, so we can.
Let's begin. That's in the wrong spot. So let's start here. Okay. So again, my name's Glenn Pfeffer. When I first got to Cedars, 15 years ago, I tried to set up a hereditary neuropathy program, but it was difficult because we didn't have the neurologists that were as passionate as I am about this. But we were so blessed over the past decade to get a tremendous group of neurologists who are world famous CMT people, like Bob Bala and Dr. Burford and Rich Lewis. So we have a tremendous program now for hereditary neuropathy. And we meet, I'm sure some of you have been there, but anyway, that's me, Cedars-Sinai, Los Angeles. I always show this funny slide. Let's see if I can just make it lower. I show this always in my talks because I think it so much shows the importance of effective communication between people. Check this out. I know My wife tells me it's dumb. She goes, "Don't show that again." But I mean, really, I mean, how many people have been in a doctor's office and felt like that? You know,
Right.
just no effective communication. All right, I have no disclosures. I have no financial interest in any CMT issues. I'm an employee of Cedars-Sinai. Cedars makes it very clear to me. They said, make our patients happy, do a good job for them, and they've been tremendously supportive of them, of my work. And I was proud, all of us. We were just recently rated Cedars the third best orthopedic department in the country by
Wow.
U.S. News and World Report. I mean, for whatever it's worth, we're all very proud of that. Now, let's see here. I'd like to just make a couple of quick announcements. One, many of you may know this, but at least for 6 weeks, I've had this Instagram account. There it is, Charcot Marie Tooth, which everyone can spell surgery, all right? And everything we're going to talk about today is on that Instagram site. So you can take a look at it. I'm still embarrassed almost for being on social media. One of my very hip residents and a 17-year-old patient who was in the office with me at the same time said, "You've got to do it. How are you especially going to reach 25-year-olds, 20-year-olds? And within 6 weeks now, I have about 400 followers. I keep blocking, which I'm not supposed to do apparently, non-CMT patients. So
Okay.
I look at everyone on this Instagram really as a family. And please text me. I'll answer your questions. I also want to try, before I forget, to encourage people to come to the H&F event where I'll be. It's called Movement in Medicine. And it's going to be in Arizona on November 8th and 9th. And I look forward to meeting many of you there. It should be a great patient-centered event. Let's get started then.
We're going to get some
Okay.
one-on-one consultations there and
Yeah,
workshops.
I'll be around for a few days, and I'm look forward to seeing people. Okay, so let me take my watch here so I don't go over. So there's a lot of great things happening with CMT now. There's a lot of really good bench research like this. There are clinical trials underway. It's just a question of time, I think, before there's a tremendous breakthroughs for helping patients with CMT, if not outright curing CMT. I won't be needed then, but it's still a day I look forward to. But for now, there are a lot of patients who have problems with their feet because CMT, especially in my world, is a foot-centric problem. I know many of you out there may be in wheelchairs. Some of you may have breathing problems, severe hand problems. But of course, what I can help with is the foot problems that affect so many people. We're doing research here at Cedars. We've published several papers and have several more coming up specifically on CMT surgery and how to accomplish the surgery. It's very exciting. A red flag, if you don't want to see something slightly, it's a cadaver specimen on research we're doing, but I'm surprised that on Instagram anyway, it has more views than almost anything. So don't look for just one slide. I'll tell you when to open your eyes. But this is a study we're doing now. This is a cadaver. And we're actually studying the best tendon transfers for people who have CMT. And we'll just leave it at that, but it's quite an advanced, remarkable study that's going on. Okay, you can open your eyes now. Okay. Now, as a brief review for CMT, it's a highly variable genotype. Now, that means there are a lot of genetic variations. I've lost count. What is it? More than 90 different genetic variations. But what's fortunate for the surgery is there isn't that much phenotypic variation. So what that means is most CMT feet look kind of alike. They're not 90 different types of CMT feet. So we can understand the phenotypes, what they look like, how they react, and how they react to surgery easier than we can with all of the genetic variations. We know a lot about CMT1A and the other types, but for those of you out there with the rarer types of CMT, you know what I'm talking about. So in terms of the foot issues, let's just break it down, not into even these 2 or 3 groups, just 2 groups. There are people who have paralysis. They don't have much function at all below the knee. Well, these are patients who need to be braced. I appreciate it if you're listening. Perhaps you have a child who you're concerned about, but there's not any real surgery that's going to be good for you. As a matter of fact, surgery could be detrimental. I see people with paralysis below the knee. They're getting ankle fusions and they're worse off. There's so many sophisticated braces now. So what we're talking about is a cavovarus foot, a high arched foot deformity. Okay, that's what my talk is about. These feet, brothers and sisters, high arches. And this is, Allison and I used to discuss this, I remember, but it really is 70% of people with CMT have these types of high arches, right? And some are very mild. Many people don't even know that they have it, right?
Right.
But they can be very severe, as you can see more in the fellow on this side. Okay. Now, what causes CMT deformity? I want to keep this really basic, all right? It's an imbalance. Who wins this arm wrestle, right? The big guy. And with CMT, because of the way the nerves are affected, some muscles gets weaker and some muscles stay stronger. So the strong muscles overpower the weak muscles. Right? If you took my arm, I'm always saying, we paralyzed the muscle back here that straightens my arm, and this muscle worked, I'd be walking around like this. So my job is to balance those muscles out. Now let's take a look at this. I can't turn these sounds off, but here's somebody, this is part of the problem where it starts. This is what happens early is the little muscles in the foot get weak, right? And when the little muscles in the foot get weak, the toes can't be stabilized. That's just the way it works. And the toes start to claw up. This alone is a problem, especially for a woman who wants to try to wear something more fashionable in Southern California. Mm-hmm. It's not the biggest deal, but it's certainly an issue. But this is where it all begins. And with these toes up like this, the foot starts to draw together and the arch starts to become higher. You can see also here, these muscles are strong on the inside, right? And these are weak. So the foot starts to turn inward. Look what's happening. How many of you out there are walking on the sides of your feet? Yeah. How many of you feel unbalanced? How many of you feel like you're really not going to be safe carrying the baby across the street because your foot's crooked like that, let alone the pain that it causes? A callus, walking on the side of your foot, and over time, there's a fracture right below that callus. Ultimately, with the foot turned in, the ankle could start to open up, and we start to develop a real perfect storm, because there's poor balance, poor proprioception, and a crooked foot. If you want a friend of yours to kind of understand what you might have in this situation, have them take their shoes off, have them walk on the sides of their feet for about a mile on concrete, and have them come back and let them know what it's like. Right? For those of you who have these types of feet, who can walk, if your friend had it who's normal, they wouldn't go a step. You've gotten used to it. Many of you may know that I had a foot problem. I think that's part of my great emotional empathy and bonding with CMT patients, because when I was 9 and 10 and 12 and 14, my coach was screaming at me, how come you're not doing this? I wasn't able to keep up on the dance floor with my friends, and I had no idea what was wrong with me. I lacked some motion in the back of my foot. I have a spur that I was born with, but I didn't know what it was until I was 40, and I'm the one who diagnosed it. My mom took me to 10 doctors. It's nothing compared to a bad CMT foot, but I understand what it is for people not to be isolated and to not understand exactly why you're going what you're going through. For those of you who had a mom that has CMT and she told you that you're going to have it, that's one thing. But many of you didn't understand why you weren't keeping up with your friends. And that's what you can end up. And this boy came down from Eureka. He really had no idea what was wrong. He just knew he had a high arch, just like I just knew I had a foot that didn't move very much, but I didn't understand it was abnormal. That's what it's like, right? Mm. When you a foot like that, you're walking with no shock absorption. It hurts. Now, people say that the CMT pain comes from a neuropathy, and it certainly does. But wouldn't anybody have pain walking like that? But I have to ask myself, how does anyone get to this point? How can we live in a country like that, like we're in, that has great health care, and someone can get to this point? Well, you know how. Insurance doesn't let people travel to see a specialist. Some people don't have insurance, right? It's still a tremendous dilemma. People can't afford often to travel with someone who really knows about CMT. And even though it's the rarest probably of uncommon foot diseases, it still is uncommon enough that most orthopedic surgeons will have never have operated on a CMT patient. Even foot and ankle specialists will only operate on perhaps one or two people a year.
Which is
It
very
took a
scary.
while for us to get up to seeing 40. What? I'm sorry? Go
But
ahead.
that's
Did I
very
say, you
scary.
okay?
How many, about how many patients have you done surgery on?
Oh, several hundred, probably, probably 300, 250 people by now. We operate on about 40 people a year, which I myself had no perspective on until I started to reach out to other doctors. And it's not, there used to be a show, for those of you old enough, The Real McCoys, about the McCoys and, the fighting. And I don't even remember, but I remember there was an older guy and he used to look out, the grandpa, and he would say, no brag, just fact. And that's just how it is. We take care of a lot of people with CMT. I see at least probably 3 new patients with CMT a week, which is just fantastic because it gives a tremendous experience, and we're able to do studies with this and understand it. So why am I here? Why am I sitting here? Why is Allison and the H&F interested in me? I told you why. I think it's my own personal history. I've been interested in CMT for 30 years, since the first patient, let me make sure of the time here, came into my office in San Francisco. She said, no one's seen my feet before. I'm 23, 22 years old. I've never been on a date. And she showed me her feet and she said, I have CMT. You know what that is, right? I think I'm still trying to make up for the lie, because I looked her right in the eye and I said, of course I know what that is. I had no idea. We didn't study it in medical school. We never saw it in residency. But I guess in some way I've taken the next 30 years of my career to make up for that. And also early in my career, I experienced what a surgeon, a doctor can experience, because probably after 5 years of her second surgery on her other foot, I got a nice email or letter that said, I'm married now, I have a kid on the way, and I'm walking. And
Wow.
anyway, so that's why I'm here. This is why I'm here. Here's a fellow who came to see me. He bears his feet, and he just couldn't walk. He didn't know what to do. I think he was from Arizona. He didn't know who to see, and he came. He was walking previously on the side of his foot. Does that arrow show up when I do it?
Yep, it does.
Yeah, but he was walking on the side of his foot. Now his foot's flat. So I'd like to just give you some of his own words, because I don't believe me. Let's listen to my patients. And I want to emphasize something before I forget. It's not all perfect. I heard from a man today from Boston who may need another operation. I have a young boy from Chicago who may need another operation. I just operated on someone from San Francisco. But they're better. They've gone from a C-. I'd hoped, as most people I think do, go to a B+ or A-, but they're better. And I would ask you all, you're going to have my email. If you're out there, tell me that you're worse, because I want to learn. We're doing studies that'll be long-term, but all I know now is every patient I see, I say, have you heard about people that have been made worse? And I haven't heard anything yet. So I think we're on the right track with how we're doing these operations. But it's not, it's a surgery. And like any surgery, there's risk to it. Listen to him. Let's listen to Michael.
My name is Michael Ponder. I'm from Arizona, and I had surgery on my feet from Dr. Pfeffer, and it changed my life. I have CMT, and for a long time, I just ignored it. I didn't stretch. I just kind of pretended like I didn't have it. And it got worse and worse. And so I had surgery on both feet, and it's really changed my life. I mean, as you can see, I have so much more motion. Yeah, so I recommend it. Anyone that has CMT that is ignoring it, is scared, I would say see Dr. Pfeffer, and you can change your life.
I asked patients that I videoed, I said, don't mention me. You don't have to even mention Cedars, but I'm not going to take it out. This is typical from my point of view. Again, I'm happy for feedback and hate mail if it's out there. That's typical. He didn't know where to go. He was scared. And I want to leave you with one important message, beautifully said by a CMT patient. CMT patients accept impairment as the new normal. You mustn't, right? If you have feet like this, you could be improved. Michael had no idea that he could be made better. I don't know how he found me. Now, I'm not against braces. This is someone who has no motion below their ankle.
Back a couple of times.
And look what the brace does for them. I would never consider operating on this person ever. I wouldn't do an ankle fusion. Look at how stunning that is.
Yes.
But that's not someone I could help with surgery.
Right.
There are many different braces out there that can be used that are terrific now. There's a tremendous choice. So you need to find a brace maker who can give you different options. But why is this happening? This is a gal who sent me, I don't want to pick on any one continent, but she's not from the United States and she's from another continent. And she said, I've seen everybody in my huge country and none of the doctors want to help me. Really?
Wow.
You're going to leave a middle-aged person with a foot like that? It's unconscionable. And what she's given is a brace. So I have a slide, I didn't put it in, of taking a square peg and putting it into a round hole. Yeah. If you know anyone, if you've corresponded with someone who has a crooked foot that's being put into a brace like that, they need an operation. So here are the goals. We want to try to avoid fusions. It's not the worst thing to do a limited fusion if it's needed. We'd like to avoid it, especially in a younger person. You have to have a foot that's flat. You can't have the foot from that previous person. We need to balance the muscle pull, right? So you're not ending up like this. And you need to get out of a brace if possible. We see a lot of patients from out of state, and I correspond with them by videos. They send me a video, and I say, I think you could have surgery. I make a commitment to take a 3-hour block of surgery time and put it aside. And then they come in a few days before surgery. I'm always so worried that I can't deliver on what I thought I could by video. It hasn't happened yet, but someone has to have some muscles functioning in their foot. That's the key. I'll see someone and they have a muscle that's functioning and I get a big smile on my face and I tell them I can deliver for you here. I just saw someone like that today. But the goal is to not be in a brace, not the end of the world, a brace. It's okay, right? But nobody wants to be in a brace if they don't have to be. And then the question always comes up is if you have strong muscles or some strong muscles, if you go into a brace, will it make them weaker? I've had different feelings on that over the years, but I think it probably does. They used to use cervical collars for muscle sprains, and they found that the muscles got so weak, the person could never get out of the collar. So if you can move your foot in some way as the bottom line, and you have some muscle function, your foot's crooked, consider an operation. Okay. And do it early, because the more the deformity progresses, the more the imbalance progresses, the harder it is. Which is going to be easier? For me to balance out my arm a year after it's happened, 6 months, or after 10 years? So you want to do it as soon as you know you can't live with that foot for the rest of your life. This 11-year-old boy, his family came from Alabama, and they know that he can't live with his foot. And he knows he's being held back. He knows that he can't round the bases. He knows that he's unbalanced. But it's very, very interesting. I discharged a young woman today, and she was walking an incredibly deformed feet. If you saw them, you'd say, who could possibly walk on feet? She's 13. She didn't want surgery. She said, I'm fine. I've got friends. I hang out. It's hard to get perspective sometimes on our life. So I'm often telling a young patient, okay, you're doing fine. Speak to your friends about it. You know, honestly ask your best girlfriend, your mom, how you're doing. Because it's hard to get that look, isn't it? In all of life, it's hard to see who we are. Because for her, that was normal. Anyway, we did her second foot, just discharged her. She's back to Arizona and she's going to have a beautiful life. And I was very, very happy. We got her feet flat. Early intervention, right? I think these people are from Florida. Here, she's 20 years old. She had one foot fighting with her dad. She didn't want it. Look at the right foot. It's just been operated on. It was basically paralyzed, not completely paralyzed. Now, that foot's about 3 months after surgery. She didn't want her foot operated on. Dad persuaded her to do it. And it was so touching. She's there at surgery, sutures in her foot. She's come back, for the first post-op visit, sutures everywhere. We take off the cast. She looks at her foot and she sees that it's flat, beautifully balanced. And she looks up and says, Daddy, I want to do the other foot now.
Aww. Yeah, sometimes.
Because right there, in spite of, you can see it. It's just immediate transformation. Now, again, how does this happen here? How does this person get to have a foot like that? Well, we talked about it before, but the reason I'm here tonight, and I think the reason that you guys are willing to do this, is if you can have surgery, if you're blessed enough to have the ability to travel to somewhere they can do it or have insurance, don't let your foot stay like this because of fear. You're not going to live with a foot like that well the rest of your life. Okay, how do we do it? We do it as an outpatient. People come in, they have their leg numbed up. It's okay to numb up a leg with CMT. We've seen many, many patients with it. There's an article in the literature that says that's fine to do. We operate, I'm a hand surgeon by training, and hand surgeons are trained in tendon transfers. So are foot and ankle surgeons, but it's just something I've always loved to do. We operate with a microscope like this. And what we do is two things, and I mentioned it. We take out bone and we move bone around, and we move soft tissue. People are kind of creeped out by the bone the most. They go, you have to do that. That's the easy part. The bone's going to heal.
Right.
It's the soft tissue balancing of the tendons that's the hardest. Here's a right ankle from the back. We take a wedge out often, move the heel over. I'm going to show it again. Push a little bit. There it is. There's the heel being moved over. You don't want that heel inward. We balance the soft tissue. We've done research papers on these things, and this boy had the same feet as this. This is after surgery. That's the next foot he's going to have done.
Night and day.
And he really had no idea. He didn't understand why he couldn't play baseball. He didn't really understand why he was falling over and he couldn't keep up with his friends. And, it was amazing. I mean, look at that. It just speaks for itself. It's just a blessing for me as a surgeon, for him as a patient. This is a problem. We're doing research on this, trying to look at the best way to do this. We've had a consortium. We met recently in Chicago with 7 past presidents of the Foot Society and multiple other doctors to try to get some uniform recommendation, but there isn't. So you go to surgeon A and he recommends this, or she, and then you go to surgeon B and they recommend something completely different. That's enough to drive you crazy. There's risk involved. These are big surgeries. At least you like to have 2 surgeons tell you the same thing. And I do not minimize this. Patients who go through these surgeries are brave people, often with family support, which is why it's good to do it at a younger age. But it's scary. My dad was a surgeon. He did big surgeries. He had a mole removed off his forehead. And he said, I found out the difference between a big operation and a small operation. He said, it's big when it's on you.
Exactly. Very true.
I don't minimize it, right? But the risk of living with it, let's see the time, I'll try to finish up here. The risk of living it with the rest of your life is a much bigger risk. You know, don't live with impairment if your foot could be made flat on the ground.
Right.
So, you know, okay. Now, the right foot was just operated on. The left is going to be operated on. The right foot was operated on about a month ago. The left here, you could see it is going to be operated on that day. That's where it's signed yes.
Wow.
Look at the difference. Even though they're scarred, I mean, it's a no-brainer, really. It's just a no-brainer. Look at the smile on this young man's face because he knows what his new feet look like. Who would ever want to have bilateral boots like that on, right? But that's not an unhappy boy. Here, this is actually the fellow who called me. He may need further surgery, but his foot is better than it was. I certainly hope I'm going to correspond with him again in the near future. Again, you know. Now look, this is a right foot that's about to be operated on. The left foot is just probably about 6 weeks after surgery. The coordination's not quite back, but which would you rather have? You know, here's another. She hadn't ever been able to wear cute shoes. She couldn't walk without falling over. Her mother said she couldn't walk for a diploma in high school to hold on to it. And, you know, she said, well, we corresponded probably for 45 days every night with text because she was having some problems. So God bless her, right? I won't go on with this. I mean, they're just pretty much all the same. Balancing tendons, cutting out some bone. Look at Sarah. Many of you may have seen this, but it's so touching or moving. I mean, they didn't know where to go in the United States. She said, all I want in my life is to be able to walk down the high school aisle without holding on to my father.
Wow.
Really. And here she is.
Go ahead.
I thought a newspaper would want to do an article about CMT recently. I contacted her mother to get in touch with Sarah. And she said, Dr. Pfeffer, I don't think you understand. She's working in a pizzeria now.
Wow.
She's going to law school. And she just walked around London in cute shoes and outdistanced me with her boyfriend. It may not always be that great, but I really believe most of them are. I'll finish up in maybe 4 or 5 minutes. Is that okay?
Absolutely.
Is that all right?
Yep.
We'll have questions. I show this because this boy was in a wheelchair. So you have to think where you're coming from. He had 2 surgeries, but look at his face. I never saw a smile until that moment. Never. And that's worth everything. And this one especially. A young man from Israel. A young man in Israel. This is the second son he's had surgery. He's not able to walk. He came from Israel for surgery. And look at his foot. It's a new foot. It'll take him a year. It'll take his brain a year to understand it. But look. I mean, really. That really says it all.
Absolutely.
This young gal's from Texas. She had surgery that had failed in Texas. It can happen. And there she is. And what a dynamic soul. Libby said, I am not wearing braces the rest of my life. You do anything you can, but I'm not wearing braces. So we did a fairly heroic surgery with her. It's rarely done. We transferred tendons that are hardly ever used for transfers, but she understood it was a long shot. But she's so happy. She's back in cute shoes. And take a look at this. She just sent this to me. How many normal people can do that? I can. But that's commitment, hard work, a family that's stuck together, and a little bit of luck.
It's fantastic.
All right. So I'm just going to give you some patients' final words. I don't mean to belabor it, but I think more than listening to me, let's listen to some of my patients.
I'm not sure what to tell you guys or what your situation is, but even if you think that, oh, this is the best I could do, this is the best my life could ever get, I believe that even though the surgery might be hard and the rehab might be hard, it will benefit you in the long run. I never thought I would be going to college on my own, just with my service dog and living on my own and being independent. And I want you to know that you can do that too.
This is my mom, Janet Mizels. We're here. I'm 26 years old, and for the first time in my life, I'm standing up with CMT without pain. And obviously, it's a very emotional experience to go through, but this was all so worth it. And I went into everyone worried, because that's the realistic emotion that you go in with. But every time I came out, I was so happy that I did this for myself. And I was so thankful to my surgeons for all the hard work they did, because I now get to walk without pain for the first time in 26 years.
Dr. Pfeffer, you are an amazing surgeon and a life changer. We are forever grateful.
Now, she's had a hard time. She's 12 weeks after surgery and some of her wounds still haven't healed. That's atypical, and she has a condition that's contributed to that. But I could look her in the eye before her surgery. I could look any patient in the eye before their surgery who has this constellation of issues and say, I promise you, you will be better. It's just a question of how much. Let's just finish up with words from Mira.
Hi, my name is Mariam. I'm here post-operatively, Dr. Pfeffer's office at Cedars, and I'm looking at my foot, and I'm happy with what I see, and I can't wait to be able to walk without using a brace, be able to not be afraid to get out of my car and walk down to the grocery store and pick up a gallon of milk and not have to worry about how I'm gonna make it from, the parking lot inside the grocery.
All right. So thank you all. I want to just show you what you can do. There's my email. Maybe after this webinar, I'll get a little behind on it, but take a video of you walking back and forth with the camera. Take a video of you sitting like this, trying to move your feet up and down. And just take a video. See how that muscle works on the left? I can help that person. I can tell them, I can get them out of a brace. I don't know for sure how long, but I haven't had anyone come back yet. If you're out there, let me know. But walking back and forth to the camera, across from the camera, and sitting like this, and then we'll talk to see if I can help. And if I can't, we can try to find somebody for you in your neighborhood. All right.
Yeah.
Thank you, everybody.
Why? Thank you so much. That was
Question.
incredible. Yeah. We have a few coming in here. Well, I think we kind of touched on this, but will the surgery last forever?
That's a very good question. I don't know the answer to that. I've been doing this though for 30 years. And as I said, I just don't see people coming back and saying, people come back for additional things. That gal who couldn't walk, who was showing me her cute shoes, we operated on the back of her feet because they were crooked. And I said, I'm worried about you when I discharged her because I think, and I was being sarcastic, I think you're doing so well, you're going to want to come back for the front of your feet.
Right. And
she said, Dr. Pfeffer, I'll never, ever be back to see you again. It was a few years later, she said, damn you. She said, I'm back. I'm doing so well. I want the front of my feet straightened out. But it's a progressive disease officially. We know that it progresses. It's probably not going to last forever, but give me a good 20 years and we'll deal with that in the future.
Okay. And then we have a question here from Donna. How long does it take to relearn to walk following surgery? I'm having surgery in 10 days. I'm terrified.
A year, depending what you have done and how old you are. But, depending what you do, Are you having surgery here at Cedars? Somewhere else?
I'm not.
But depending, regardless, it takes 10 weeks for all the tissues to heal up. Then it takes another 2 or 3 months of physical therapy, but it'll take a year for your brain to relearn things. It doesn't mean that you're limping around, but don't give up. A year later, you'll be walking and understand the complete fruition of the work that was done. It's completely normal to be terrified. I had foot surgery. I was kind of terrified, but
Yeah.
you'll be fine. You'll be, as long as,
can-
I just make sure your doctor knows about CMT. I don't know what to say about that. Let's leave it at that. Just make sure your doctors knows about it and does a lot of CMT work.
Yeah. And I also had, I had surgery at 12 years old. I had the ankle fusion, but I also had my deformities of my feet. I was walking on the outside of my feet. So a lot of those videos could have been my own feet as well. And it was probably one of the best things I did, my parents did for me. Completely straightened out my feet. I've been able to wear braces since without any complications. And one thing I wanted to note too is just the effect that those type of foot deformities have on the rest of your body. I mean, that goes up to your knees, up to your hips, up to your back. So it's kind of like a chain reaction when you're walking on feet with those type of deformities.
Oh, absolutely. My left foot after surgery still hurts. And what's the worst part? My hip. I kind of stand funny all day, on the side. At the end of the day, my right hip is sore. So you're absolutely right about that. I'm glad you're doing so well.
Yeah.
Anything else?
We had someone here, is 73 years old too old to have surgery?
No, it depends how you're doing. 73 today is what 93 was when I was a kid. Oh my God. I don't know who's out there, but I remember being, 20 and looking at a 73-year-old and going, oh my God, are they old? Not anymore. My mom's 94. And,
Wow.
God bless you if you're going to live to 94 and then make the last couple of decades count. But remember, people are doing surgery. You should do surgery when you get a perspective that you're not doing well because your feet are crooked and you're imbalanced and you're falling over. If you're okay in a brace, forget what I said. If you're okay in a brace, especially at 73, stick it out. But at 23, it's really inappropriate. At 73, we're not all that different age, you and I. So, we have the last quarter of our lives to live, and maybe not as much stress on it.
Right.
But if you're not doing well in the brace and you're imbalanced, absolutely have surgery. The oldest person I've operated on was 78. And it gets harder. I can tell you this, if you're not going to do it now, you're never going to do it. If you came to me at 80 and said I'd like surgery, I'd be very, very shy to do it.
Okay, makes sense. Then we had another question. Do you always cut the bone in surgery?
Yeah, it's interesting. People are scared of the bone getting cut, aren't they? It sounds just like horrific. But I would say almost 100% of the time the bone has to get cut because it's twisted. It's deformed. For people who develop CMT at an early age, the bone actually grows with a curve in it. It actually grows abnormally. But that's the least of the issues. The bone will heal. The bone will do beautifully. It's how to figure out to balance the soft tissue that's what becomes the challenge. And of course, the soft tissue means the muscles. And that's the real problem with CMT. So you just don't know how these muscles are going to respond always. There are patterns, as we talked about before, but don't worry about the bone getting cut. That's not a problem. I saw something online once, somebody was saying, my surgeon had the audacity to tell me he was going to saw through the bone. It wasn't about me, but about someone else. saw through the bone and put screws in it. You know, that's what orthopedic surgeons do.
That's what it
And
takes to
don't worry
fix it.
about that
Yeah.
part.
Okay, then we had another one here from Juan. What about fusing hammer toes? Is there any other ways to correct that?
That's an interesting point. I never fuse hammer toes. Ever fuse hammer toes. The treatment for hammer toes in general for non-CMT patients, or some people fuse them
Okay.
and they put little implants in. And some people like me take out some bone and then you pin the toes for a while. I like doing it that way because the toes don't stay perfectly straight or perfectly bent. They'll find their own place. Controversial. I could only say at the recent CMT think tank that I hosted, when I asked the group, maybe I forget totally, 17 people, 17 orthopedic surgeons, said, how many of you are fusing toes with implants? Because that's often how you do it. Not one of them does it that way. Controversial. It's okay if you do it that way. I just tend not to, and don't tend to like it because I think it gives you too stiff a toe. You want to have some feeling with CMT, don't you? You want to have some sense of the ground. And I think if the toes get a little bend back after the hammer toe surgery, you're better off. But it's not proven, and it's okay to do.
Okay. And then we had two more questions. One from Beth. I had a fusion that never fused. Would you be able to redo it?
Yes.
Okay. I thought
That's
we
easy.
figured that. That's an easy one. And then one from
But if it doesn't, one thing is still, if it doesn't fuse, it's not so bad if it doesn't hurt. But if it hurts, then you should have it redone. There are a lot of reasons that fusions don't work. Again, it's a complicated topic. The fusions that we do, I have close to a probably 97% fusion success rate. And you can refuse it using your own bone, using some chemicals that are safe and will fuse the bone again. But don't live with a joint that's painful. It's not fused. That's easy. We'll just fix it up for you.
Okay. And then Donna asked, why would a surgeon need to cut behind the knee to access the tendon in foot surgery?
I'm sorry, once more, Donna?
Why would a surgeon need to cut behind the knee to access the tendon in foot surgery?
They wouldn't. I think maybe there's a misunderstanding there. You might have to cut in the calf muscle to lengthen the tendon, but behind the knee would never have to be done.
Okay.
The issue of a contracture, where someone's walking on their toes or their ankle is down a little bit, is very controversial in CMT surgery. Sometimes the Achilles in the back of the heel needs to be lengthened. Sometimes the calf muscle needs to be lengthened. But it's not common that has to be done. But going into the knee would never have to be done.
Gotcha. Okay. And then one last one here. If the muscles are not working because of the nerve damage, will the surgery improve that at all?
Oops, all right. Well, that's my last slide. I didn't mean to put that on, but if the nerve is damaged,
if the muscles aren't working to begin with, will there be any improvement after surgery?
I want to make this, they're lumpers and they're splitters, and we can talk literally for a month if we're going to split this. Let's lump it again, and this is really important. This is my take-home message. If there's no function in the muscles, or very little function in the muscles below the knee, perhaps as you had, and the foot's flat on the ground, get a brace. There are braces that are remarkable now. It's the space age of braces. And you will walk like that young woman very fluidly. In most cases like that, surgery's not going to be helpful and actually could be detrimental, because it'll take away the spring action of the brace that lets you walk with stored energy from the brace. So that's someone who has no muscle function. In someone whose foot is not flat on the ground, it's called plantigrade, flat on the ground. There can be two types of people. One, where there's been overpull of the muscles and the muscles still work, having a surgery. And the other is where the muscles used to work and twisted the foot around, but they don't work anymore, have an operation.
Right.
So if you have no muscle function and your foot's flat on the ground, go to a brace maker who could show you different types of braces. The problem is many brace makers only have one brace or two braces, right? Would you ever go shopping for a dress or a suit and the company would say, here's your size, right? You never would. So you want to go to a brace maker who has many different types of braces to try on. But if your foot's not flat on the ground, whether your muscles work or not, get an operation. Does that help with that?
Absolutely. I think that clears it up for a lot of us. Yeah, and we just wanted to say thank you so much for speaking with us tonight. I think this webinar has already helped a lot of people. We got a lot of thank yous there in the chat windows, and people who are about to, start this surgery journey. And I think you alleviated a lot of their anxieties. So I'm sure they're very grateful for that. And for anyone watching this in the future who's thinking about surgery, I think it'll be extremely helpful. So we thank you again, and we can't wait to see you. And for anyone interested in learning more and getting even a one-on-one consultation at our summit, please visit movementismedicine.com, and you can register for our amazing summit in Phoenix, Arizona, November 8th and 9th. Dr. Pfeffer will be hosting a workshop there and also speaking with patients and interacting with them all weekend. So it'll be a wonderful event. You'll be able to connect with, dozens and dozens of other CMT patients. And I think that's one of my favorite parts of these events, is that just getting everybody together in one room and making those bonds and those friendships that we could all help support each other with. So thank you, Glenn. Dr.
Thank you. Goodbye, everybody.
Thank you. Have a good
Bye.
night, everyone. Talk soon.